the area that is very interesting, and I think that there's got to be more awareness, is this ocular neuropathic pain. And this is pain, another way for this is pain without stain. Somebody comes in your office and they have tremendous pain, right? Because you look at their cornea and you say, gosh, this is a normal cornea. You dilate the eye, normal retina. And you look at their lids and everything is normal. And this gets back to this neuropathic pain. It's a real phenomena. And it's a phenomena that we need to understand, because not only can you get neuropathic pain with LASIK and other procedures, you can get it with any surgery, any trauma. You can even get it with chronic contact lens use. And the thing about it is it's pain initiated or sustained by, and it's basically dysfunctional elements. It's dysfunctional neurobiology of the pain pathway. This is an example which shows the neurons, or a sort of a schematic which kind of explains this. In a normal stimulus situation, you stimulate the surface, okay, and it goes to the second order neuron in the trigeminal ganglion, and then that goes to the brain. Now, what's really interesting about neuropathic pain, at least in the cornea and other places, is that you can have the corneal nerves can be irritated, and they can be dysfunctional, and they can just start firing off stuff. Okay, they're just firing away with nothing. Okay, and that then sends to the trigeminal ganglion where you get pain. What's really painful to think about is you can have totally normal corneal nerves, but because you had this pain pathway that was set up, now the trigeminal ganglion is going crazy, and it keeps sending signals to the brain. So that's that patient who comes into your office who is just miserable because they have so much pain, and you look at their cornea, and it looks totally normal. There's no staining, there's no nothing. You then do everything, it looks normal. And then you send it to your cornea specialist who has the confocal microscope, and then they do the confocal microscope, and they look at it, and they say, the corneal nerves are normal. It's not makeup, it's real. And it's real because they have pain in their trigeminal ganglion. I mean, what's scary about it is that you can be a perfect surgeon and this can happen to you. We know that, however, there are places and situations where you can have changes in the cornea. Okay, and there's a so-called subbasal nerve density can change, and they can look at tortuosity and beating and those interesting pictures, and they can try to come up with ideas about, making associations with it. But it's not 100% because it's a pain syndrome. What's really fascinating is that you get, not only do you have changes obviously in the structure, but you have a lot of changes at the synapse. The synapse changes where they have synaptic connections between the pain fibers and the the actual synapse actually biochemically changes. We have a vesicle here. When I was doing my PhD at Stanford, I worked I was in a synapse lab. I mean, we were looking on synaptic plasticity, and we were looking at how changes occur at the single cell level. And we had the luxury, okay, of being able to take out the ganglion from aplysia, which is this awesome big sea slug. And we put it on our culture dish, and we could be very precise. But with humans, you're talking about a living system. It's a complex thing. We do not have answers yet. We have a lot of knowledge about it, but we don't have answers. One thing we do know about neuropathic pain is that there are mechanisms to reverse it. So this is not all doom and gloom. You can actually with the appropriate, you can actually set up resolvins and neuroprotectants, and so you can have this tremendously horrible pain pathway, but then you can actually block it, and you can actually reverse neuropathic pain. So neuropathic pain doesn't have to be something that the patients live with their whole life, but sometimes it is.